Putting it on YouTube right now. Putting it on the web page. Hold on. Okay, here we go. Okay, 10, 9, 8, 7, 6, 5, 4. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. We have the honor of having Iype Cherian, a well-known teacher of neurosurgery and a big proponent of cysternostomy, which he's going to do a lecture next Sunday, same time. And today, Iype's going to talk about innovations. Okay, Iype, it's all yours.
John, thank you very much. It's always an honor to be here. We started this off almost 10 years back with John, and I have seen how this platform has grown and how it has been. I would say it has been one of the most relevant things in neurosurgical education in the last 10 years. It is something that has completely changed the way neurosurgical education is looked at. Now, my passion has always been change. Sometimes the change is radical, and sometimes the change is not very disruptive, it is gradual. I leave the gradual change to others, and I like disruptions. So today I'm going to talk about one another thing that we have done. I mean, over the next few weeks, I'll talk about disruptions that we have done. But today I'll talk to you about something that will really impact all your clinical practice. And that is about something which we have done for the last 7 years in strokes. And we thought it is the right time for us to talk about it. So again, when I started cysternostomy, it was extremely disruptive. And I remember it was controversial. But when I say this, I'm sure this will be controversial as well. So, but I think without controversies, there is nothing that anybody can do. So if you have to have if you have to have something disruptive, it has to be controversy. So now, what I'm about to say is, strokes, when you have only 1% of strokes, even in the United States, reaching centers of intervention in the golden period. You have only 1% of them, even in the United States. Only the city people can do that. I mean, we know that in India, South America, and Africa, it is not the cities which predominate. It is the second tier, third tier cities. It's not the metros which predominate. So here, getting people to reach the intervention suite within 3 or 6 hours is going to be almost impossible. So therefore, we looked at what are the other solutions that can be for stroke, and we found some very interesting things. Let us say
it's not in full screen. Do you want to put it on presentation mode?
Right. Can you see that right now?
Yeah, it's perfect.
Yeah, so when we look at strokes immediately and we look at a CT perfusion, it can be anywhere from an umbra like this and a penumbra like that, or in worst scenario, you have an umbra like that and a penumbra which is like this. So there are some important things to know. Whenever there is a stroke, you must understand that The M4, M1, M2, and M3 vessels don't communicate between each other too much. They don't communicate. They are end vessels. But the M4 vessels, they are very well connected. They're very well connected. So therefore, if you have a stroke, there is a region of penumbra which is area of death. There's nothing much you can do about it. But there's an area which is the penumbra. Why the penumbra is important is because the penumbra is not really dead. It is not dead, but not functional. The second thing important about the penumbra is that it is the area that can transfer the function from the umbra to that particular area. You cannot transfer these functions to somewhere here. It's impossible. If you want to transfer the functions, you have to transfer the function from the umbra to the penumbra. So over 7 years and 55 patients now, what we realized is if we can do an ST to M4 anastomosis, not ST to M2, not ST to M3, even ST to M4 anastomosis, then what we can do is we can improve the perfusion in the penumbra. That is first thing. Of course, just improving the perfusion in the penumbra is not enough. We have to have a rehab system which can reroute or reboot the brain. As my colleague from Bangalore, Dr. Srinivasan says, you have to reboot that functional brain. So you have to first get that functional brain in from a non-functional brain. Second thing is you have to train that brain. So we started working on this now. So, in the first few years, we had till 2025, we had about 31 patients. This was a single surgeon. This is just my experience. You add 3 surgeons now. I mean, we have in India right now, we have we are hoping to start a trial between AIMS, ourselves, NIMHANS, and probably Chitra. And Vellore is also signing up. This would be a massive trial. These are the large 5 centers. Our center not being that large or anything, but it's still a scheme hospital in the western part of India. It's a free hospital. It's a charity hospital. So that we have enough and more patients for stroke. And I'm sure with the addition of AIMS, which is one of the largest, if not the largest center in India, and add that to NIMHANS, Vellore, and Srijitra, which are dealing with large neurosurgical diseases, I think pan-India wise, we will have a lot of patients more. Right now, at the moment when I'm talking to you, we have almost 55 patients. About 30 patients we've analyzed, and we've seen that there are incomplete MCA strokes, multiple RINDs, reverse ischemic neurological deficits not improving with medications, no AF or cardiac abnormalities. Then we have a DSA and MR angio to assess the vascularity with algorithms to show that the perfusion with AI is being developed, rehabilitation, and we've had 1 death due to an ischemic cardiac event, 8th postoperative day, and 4 transient deteriorations, and significant positive difference in GOS at 6 months compared to patients just on medication. Now, salvaging the penumbra, what is the hypothesis? What are we talking about? So beyond the acute intervention window, the low flow STA M4 bypass can, number 1, improve perfusion in the viable peri-infarct cortex, that's the penumbra. Facilitate functional shift from infarcted umbra to penumbra through neuroplasticity. Reduce recurrent ischemic events compared to the medical therapy alone. This is the benefit. And we're talking about quite a large population. We're talking about strokes, and strokes form one of the largest causes for morbidity above 50 in populations all over the world. It's not just first world, second world, third world. Above 50, one of the largest morbidities is strokes, way more than any cancer. So where are we now? The recent CMOS, that is a RCT, it was a symptomatic ICMC occlusion with hemodynamic insufficiency. They found no reduction in stroke death with bypass. But the problem was, these are not M4 bypasses. The JET1, JET2, the CMOS, they are not really M4 bypasses. So the question is, where is that sweet spot? The JET1 and JET2 suggest that the sweet spot is very narrow, but we believe that if you can anastomose to the M4 rather than M2 or M3 that's being routinely done, if you have a CT perfusion or an MR perfusion or algorithms from where DSA perfusion can be worked out and then do it to M4 selectively, this is where we think the most impactful thing is. And also what we think is just having a functional brain is not enough. You have to train that functional brain. And so neurorehabilitation becomes very important. So the innovation in this study that I am proposing to you, it moves bypass from a global flow augmentation, that is the ECIC, COS, and CMOS, to precise salvage of residual penumbra. It has to consider that M4s are connected into a network. It integrates plasticity biomarkers like fMRI, TMS into outcome analysis and tailored to an eloquent hyperperfused cortex where rehabilitation gains depend on improved substrate. Now, we will show you an anastomosis. It's, of course, it is at the highest zoom. You can see the preparation of ST. Yesterday, I was sitting with my team, training my team again in STMC anastomosis, because we feel that this is one of the surgeries all over the world that's going to come back into vogue. And if you can do bypass, that skill nobody can ever take away from you. If you have to do a skull-base tumor, if you have to do a large aneurysm, you need anastomosis. And the people who will benefit the max from this low flow selective anastomosis would be stroke patients. So that is why we believe that this surgery is going to, make a massive comeback. I mean, Yasagil, during the times that I have seen him many times, he was very unhappy about the trial, which finished off. Now we know the trial was not designed very well. And to assume that a bypass is only as good as or inferior to medical therapy, while the cardiac bypasses has taken off so much, it just shows how probably how wrong that trial was. I mean, you have one organ bypasses taking off like anything, and then you have the brain, the same vessels, and you say that medical treatment is the same. Of course, you have technical difficulties there, and you have people who are not willing to do proper bypasses, and you have surgeons who are very inexperienced who probably has been enrolled in that trial. So you can see how is that we are doing the bypass. This is using the exoscope, sometimes zooms up to 50. So 0.4 to 0.5 millimeter vessels. Typically, we have designed our own set. Earlier, the sets were costing us, even a scissor was costing us $800. So this entire set we have designed in such a way that, the best set ready for ultra micro neurosurgery, the entire set doesn't cost you more than $400. So less than half of scissor. So that way, all the people, all the residents, everybody can afford it for practice. I mean, otherwise you cannot even think of buying a set with a few thousands of dollars for practice. So now we are offering the opportunity for everybody to take it for practice and use the same set for surgery. Okay, use the same set for surgery. That's what. So, and we are pushing the limits of the Zoom with Zooms and the technique. And we are asking boys, and we're pushing ourselves as well, trying, doing all the knots, different types of knots, different types of difficulties, depth bypasses, all that. We are pushing this so that we know that, in a few years, this is going to be a norm. Bypass, if you don't know bypass surgery, you will be seriously, more than your patient, you will be the person whose GOS is less. So you can see now we're putting about 6 sutures on each side. I use most of the time 11-0, sometimes 10-0 if the vessel is big enough. And you can see how that bypass looks now. You can see 1, 2, 3, 4, 5, 6, and 12 sutures in total. And there should be no leak at all. So this is after the bypass. So after that, you see this is filling. That's a bypass site, and that's filling. Now, this is another innovation that we bring. This is ultra micro neurosurgery. This is operating at zooms of more than 40x. People ask me, what is the need for this? It is the same question 50 years back. What is the need for micro neurosurgery? Now I'll show you ultra micro neurosurgery. This is what we do. This is a simple sylvian dissection. It's a 3-hand technique, that is surgeon and the assistant, and 3-hand technique for a sylvian dissection. You can see there is not a drop of blood. Okay, no blunt dissection at all. Everything sharp, and 3 hands are always in the picture. And you can see small vessels, very, very small vessels being dissected, and the sylvian is just opened. I used to remember Professor Sano opening sylvian beautifully. We have tried to follow in the same way, but much more magnified. You can see when it says the zoom is 5.18 on this exoscope, on the 56-inch screen that I am seeing, it's about 51.8 zoom. It's almost 9.8 times magnified. This is nearly 50 zoom that I'm talking about on a 56-inch screen. And with the Sanma Yoko exoscope right now that we have in Parul, we're looking at almost 150 magnification. People may think it's crazy, but all I have to say is you got to train your hand for that. Okay. Now you're seriously getting into F1 skill territory. No more can you just pass out an exam with just some written exam, and then you cannot be called a neurosurgeon, just like a footballer who cannot be called a footballer by just passing a written exam about history of football and techniques in football. If you write a written exam and if you pass and if you can be called a footballer, that is exactly what I think about a neurosurgeon being called a neurosurgeon without really being trained in the lab without being trained for these kind of high-level surgeries. So we believe innovation should be in training as well, in understanding the anatomy, in having skills, in being assessed for mental toughness. Because if you're doing big cases, you can have failures. And if you're the type of person who says, okay, I'm not going to do this surgery anymore, even after learning so much from each of your failure, you're not fit for that, you're not fit for that branch. You can see now how I go between the veins, taking off all the arachnoid there, getting help from my colleague. Opening up, further opening up. You must see it's a wet field, always a wet field. I would like a wet field more than a wet dry field. Are you going further? Each strand of arachnoid being taken away, going to the optic nerve, and you can see that bit of vessel. You consistently find that vessel, and it's important that you save it. This is the way to save it. So you open that arachnoid, and that vessel is generally going to the underside of the optic nerve. And you save it, and then you come back again and go to the opposite optic nerve. You can go all the way up to the MCA with this beautiful bloodless dissection technique. Under the highest magnification. Go all the way up to the opposite optic nerve. Each of these, there's no need to divide any of these vessels. You find the plane between them and keep on dissecting this, go all the way up to the contralateral MCA. You can see this side optic nerve, contralateral optic nerve. You see the contralateral carotid there down. So this is a little bit of tension and a little bit of dissection. So tension and dissection, tension and dissection. And sharp, all the time sharp. Now the contralateral carotid opens up and go further again. So that is both optic nerves. Every single small vessel is spared. Right. So when you're doing an anastomosis, coming back to the anastomosis, things to avoid is stretch of vessels, stitches inside. That is, if it's not everted, then your anastomosis is for sure failing. Then one of the things we found out, that we should never use is cotton fiber patties. You should not have cotton fiber patties. These fibers are very small. If they get stuck into one anastomosis, your anastomosis is finished. Taper cutting needles, they should be the one you should have rather than spatulated needles. Okay, that taper cutting, you should use taper cutting needles than spatulated needles. Spatulated needles is what Ophthal uses. So you should not be using them. And needles more than 5 millimeter is very difficult with small vessels. You should go for 4 millimeter or 3.8 millimeter vessels. And before every surgery, you should practice. Don't think that I've done 1,000 aneurysms, 1,000 bypasses, so let's just walk into the theater. No, you should practice just before surgery. It's extremely important. Don't do forearm exercises. I am into fitness, but I cannot afford to do forearm exercises. I cannot have lack of sleep, tea or coffee before surgery. This is my perspective. You want to do forearm exercises and go for a, 0.4 millimeter vessel anastomosis, be my guest. Okay. Or there are many anastomosis, excellent anastomosis surgeons who take a lot of coffee and tea, but I find that there can be very, very minimal tremor if you are doing this. And if you have any discomfort during surgery, like if your sitting position is not okay, your hands are not okay, correct that first before you do an anastomosis. Very, very important. Okay. Now, this is probably something that we can claim that it is one of the smallest anastomosis ever done in the world. This is a 0.25 millimeter vessel. Okay, maybe Takashi can tell me if the Japanese or anybody has done these small vessels. It's a 0.25. This is a 0.7 millimeter, 0.6 to 0.7 millimeter ST. And this is a 0.25 millimeter MC. We had an excellent, we have the recordings here. We have excellent Doppler signature here. This is something that we did. So is it possible to do small vessels? Yes, very much. So future directions would be collaborations with multiple centers, microneurosurgery for trauma cystinostomy instead of DC, microanastomosis for stroke, sometimes need to be combined with DC with ST preservation. If it's too late, both these surgeries will never be replaced by interventions, gamma knife, or, it will not go to critical care. So these are our bypass sets. This is another thing that we've been doing. This is mindset training. This is for neurosurgeons to train their minds just like an elite athlete. How to take off all the clutter in your mind, all the confusion in your mind. Use your knowledge to the best without fear, without any anxiousness. And if something happens, how do you repair it again without any clutter, fear, anxiousness, or visceral responses? This program is called Beyond Flow, and we train people. This is the new OR in Parul. Many has seen my OR in Maharashtra Karat. So this would be a few steps ahead. This would be an open MR. Inside the theater, it should not be a two-room solution. We combine, it's called DRIS for Drishya. This is what we designed with the Time Medicals. And the exoscope is with Sanma. So it is called Sanma Yoko. It's a third generation intuitive exoscope. So which means there is not much need for you to operate the exoscope. It will follow your instruments. And it works on voice commands as well. This is by June, anybody who's traveling to Parul will see this MRI. This is where we started. This is where we started in 2014 in Alicante with 2 universal robots as exoscopes. We designed that. We did all that with head movements. We hacked the navigation system, and we did this. And today, this is where we are, this intuitive exoscope named after my daughter, who was named after Yoko Kato. So it's called the Sanma Yoko. It has its own navigation. It's intuitive, and it's got 150 zoom. So that's a robot. It's an intuitive robot, which is way better than any of the robots at the moment available. And this is what we do when we are not really doing neurosurgery. So skills are for everything. So it is just not neurosurgery. This is a tall boy design Jeep. And if you have to drift it, you will need serious skill because it's very easy to just flip. And flipping in a Jeep like this will be, equivalent to quadriplegia. You can go ahead and injure your neck. So flipping at that speed, so that'll be bad. So this is what we do. And this was about the mind control. This is a paper that we wrote. This is what we do. And thank you very much from Paril University. So, Vadodara, this is where we are right now. You're all welcome. January, we are inaugurating. We all hope that we can host you here and show you what we are doing. Thank you very much.
Okay, thank you very much for your time. Any questions or comments from the panelists? Nick has a question. Go ahead, Nick, and he's a neurosurgeon from Greece. Hello, Nick.
Yeah, please. Yes, Nick, please.
Yes, we know each other since Zoom meetings. You are amazing presentation as always. Compliments. The only it is not a question, only a mention. Okay, this is a very good technology support, but sometimes we are not able to be available to get available in order of the cost. This is a question, and perhaps also in your practice you have mainly the same things. And the second thing, as we mentioned with John Bennett also in the previous neurosurgical TV meetings, is how we have to train our young residents and our young fellows. We have first to train them in the classical approaches, with the classical neurosurgical approaches, and after in these new elements and new technology that are very helpful. It is no question that they are very helpful, and perhaps they allow us to perform a better neurosurgery and better surgical approaches. This is the two main questions. Compliments, best wishes, and perhaps in the future, if we have peace around the world, this is also a good question. I will travel in order to see your activity. Thank you very much. A very nice presentation. Compliments. Very nice.
Thank you, Nicholas. And we are all in Greece in June last week. We are all in Greece. We are coming to Greece. We'll be there for a week or so. One of my good friends, Vasilios Oikonomidis, is doing this meeting for the WFNS Innovation Committee, of which I happen to be chairing the committee with Albert.
In which place it will be?
In Athens.
La Placa.
Is this possible to share in chat the link of the Congress? Because you are speaking about skull-based World Congress that it will be in June.
No. It is the WFNS Innovation Committee meeting. So this is neurosurgeons, companies, AI engineers, experts in machining, all those guys. We are sitting down together. And then Luis Borba, the president of WFNS, is also going to be there. And we are sitting down together.
Can you share in the chat the link, please?
Yes, I will share.
Thank you. Yeah, I'd love to televise that if possible.
John, can you give Nick my WhatsApp contact, please, so that I can share all the necessary details to him?
Or maybe better the email. I don't have
WhatsApp.
Okay.
I'll get it to you, Nick. Nick.
Thank you very much.
Thank you very much. To me, I'll put it on my WhatsApp.
Yeah, thank you, Nick.
Yeah, Plaka is the most wonderful place in the world. You have a view of the Acropolis. It's a wonderful place to stay. I mean,
we're looking forward to be there.
Yeah, it's an amazing place if you like history. Let's see, Nakashi, you know Takashi, I think.
Yeah.
Yes, of course.
Yeah, of course. Thank you, Iype. So the wonderful lecture. I'm thinking about cystinostomy. So that should be very effective. So rather than decompressive craniectomy, because of the severe head trauma, head injury, so we encounter many patients. So we read your paper and learned from the experience from your lecture. So we try to distribute this procedure in Japan. Also, sometimes in Japan is still we believe that the compressive craniectomy, but your procedure should be dispersed or widely accepted. So in Japanese Society of Neurotrauma Surgery. So we recommend to participate many Japanese neurosurgeons to learn from you your cystinostomy. And about
Thank you,
your
Takashi.
institute, yeah, and your institute is very like the space and the like good theater. So we would visit to see your institute later.
You're very welcome. It'll be our honor to host you and other Japanese neurosurgeons, considering that my learning was from Professor Sano, Professor Kato. And so I would be very honored to host you here.
Thank you. Thank you.
I'd like to meet Ronaldo Ramirez. He's a neurosurgeon from Tabasco, Mexico. Do you have any comments, Ronaldo, for Iype?
Very awesome presentation, Professor Cherian. Have any question? Maybe a simple question. Would you like to analyze the hemodynamic criteria that separate a candidate for stenting from one who require a bypass?
I could not hear that question properly. I could not hear it. I mean, maybe your net was breaking up a little bit. So if you can tell me once more or even type it, I would be happy to.
Yes, would you like to analyze the hemodynamic criteria that separate a candidate for stenting from one who requires a bypass? Sorry.
Yeah, so we are still, I mean, although we have had 55 patients between three centers, we have analyzed only around 31 till now, and we are just using this to gather data. We are in the initial stages. We know that this will work for a lot of patients if done properly, but we do not have a criteria as such. Maybe in the coming years we will have.
Okay. Thank you. Thank you. Thank you, sir.
Okay, Sunday just arrived here. Oh, do you have any comments, Sunday, Nama? Can you hear me, Sunday, Nama? You just came in here, perhaps not. Okay, any other comments from the panel? Okay, very good. Okay, thanks for your time. And don't forget,
Thank you.
next week, cystinostomy, you can get
Yes.
3 or 4 webcasts the same time. And
Yeah,
thanks
so next Sunday, same time, cystinostomy, and then after that, I'll keep on talking about our minimally invasive approaches like the mosaic approach for anterolateral, XPA-JUF for glomus jugulare tumors, our new drills, I mean, for minimally invasive approaches and the intra-op MRI, how we use AI for our theater, all
be
this,
great.
and our new systems of education with the 3D VR and segmentation and all that. So
That would
we'll
be
keep
great.
on talking about this Sundays, and we'll see how we can build this up.
Very good. Okay, everyone, thanks for coming and have a great Sunday. Stick
Okay.
around.